Dear colleagues, I will talk about a short review on ICSI of microthese in cases of non-obstructive azoospermia, and I will discuss about the problem if it is better to use fresh or frozen sperm for ICSI coming from microthese. Currently, allowing a man affected of non-obstructive azoospermia to father his own biological children is one of the greatest changes in reproductive medicine. Sperm retrieval in NOA can be performed with different surgical techniques. Fine needle aspiration, currently excluded from the AAU guidelines. The conventional these, now considered a suboptimal procedure, and microthese, which is considered the gold standard procedure. For 2 decades, a long dispute was carried on between supporters of conventional these versus microthese. This is no longer debatable today, after this paper showed that the microthese obtains higher success rate than, than conventional these. You see in 49 versus 35%, and specifically in cases of Sertoli cell-only syndrome, which represents the highest percentage of the patient with non-obstructive azoospermia. Microthese offers the advantage of identifying, using an operative microscope, the seminiferous tubules with normal caliber, which are more likely to have a complete spermatogenesis. Their selective excision usually results in positive sperm retrieval and minimizes testicular tissue damage and risk of surgical complication. My personal variance is using an operative high magnification increased to 36, which helps to improve discrimination between tubules that, at a lower magnification, may appear of a comparable size. We showed recently that a positive retrieval was obtained from the superficial part of the testis only in 26% of the total of the positive testes, and specifically only in about 18% of the total of the positive Sertoli cell-only testes. And our data indirectly support the superiority of microthese versus conventional these, in which the tissue fragment is thick, lower than 5 millimeters. Microthese requires a high-level expertise of both as a microsurgeon and the biologist assigned to search for sperm in the testicular fragments. The surgical procedure is time-consuming, and for this reason, microthese is usually scheduled on a day convenient for the team. And in case of successful retrieval, spermatozoa are frozen and ICSI are performed on a later date using thawed spermatozoa. But how to provide the NOA patients with the highest possibility to father their own children? Canadian guidelines stated in 2015, the testicular sperm extraction procedure should be offered to all men with NOA, but should only be undertaken in a center with expertise in microthese and where an ICSI laboratory with expertise in handling these samples is available. So, how to acquire microsurgical expertise in microthese? Ishikawa showed that there is a long learning curve, and you need at least 100 microthese performed, to reach what happens. I have a completely darker screen. Yes, no problem. I can. Well, sorry. How to acquire a biological expertise in microthese? Sorry, but I must be here. Yes, okay, thanks. Okay. How to acquire a biological expertise in microthese. This slide summarizes the steps of the sperm processing after surgery, traditional biological steps developed by Schlegel. And it is clear that the longer time you use to dedicate to search for sperm, the higher success rate you will obtain. In 2021, Escherman of the group of STVS performed a review on all the articles related to microthese, and he summarized, in naive population, the sperm retrieval rate by microthese was 46%. In men who failed previous sperm retrieval by other methods, the sperm retrieval rate was 39%. Clinical pregnancy rate was obtained in 39% and live birth rate in 24% per embryo transfer, respectively. And the female newborns are more frequent than the males. How to improve biological expertise in handling microthese? A fine panorama of the biological procedure to improve quantity and quality of sperm retrieval was performed and presented recently by Professor Aidos. I point your attention mainly on the enzymatic digestion by collagenase or other enzymes, on motility enhancers, on the use of sperm after short-term culture or for simultaneous ICSI, with a warning that culturing testicular sperm for up to 1 day increases DNA fragmentation. How to improve microsurgical expertise in microthese? This is my personal story, and you can see that when I was in São Paulo in these years, I had an overall sperm retrieval rate. Sorry, wait goes. 39%, and in Procrea in 55% in these years. This overall sperm retrieval, but limiting only to the naive patients, you can see that in the recent year we obtained 58% success. And we tried also to improve biological expertise in microthese with a long series of procedures which are here summarized, but I don't want to lose time. And this is our biological classification of sperm retrieval. You can see our sperm quantity as poor, classified as poor, moderate, good, or excellent, depending on the number of sperm. So, according to the criteria of embryo laboratory, only normal morphology spermatozoa could be used for ICSI. But Chen underlined that 60% of the positive cases gave up further ICSI treatment, either due to severely abnormal sperm morphology or to complete sperm immotility. Well, and the group of Professor Schlegel challenged this sentence, this conclusion, with a sort of a new course, because he showed that the overall fertilization rate by ICSI with sperm by microthese was 44%, and the clinical pregnancy rate was 38 per transfer, per embryo transfer. But you can see here that about motility, these are the results in case of used motile sperm compared with immotile sperm, 20% in case of fertilization rate, and clinical pregnancy rate decreased from 44 to 19%. And using only abnormal sperm, clearly motile, the fertilization rate decreased to 35% and the clinical pregnancy rate 27%. So it was a broken dogma, that is, in case you need and you have no other possibility, you can use abnormal sperm or immotile sperm, even clearly, although if they are live. So, but frozen thawed sperm or fresh sperm. Meta-analysis showed that the same result using in terms of fertilization rate, good embryo rate, clinical pregnancy rate, implantation rate, live birth rate. However, the cryopreservation methods vary among the laboratory, and cryopreservation thawing can induce sperm damage. A potential risk to be considered is testicular sperm loss after freezing and thawing, as the survival of frozen thawed samples is not uniform in all centers. You can see the huge difference. Chen observed that poor of sperm motility, sperm quality is eliminated by freezing thaw procedure. The rare sperm may be lost during the thawing procedure, and using fresh sperm for ICSI would be an appropriate choice in such condition. Summarizing, the advantage of using frozen sperm from microthese is ovarian stimulation and oocyte pickup can be avoided in case of negative sperm retrieval. And the disadvantages are freezing and thawing procedures result in a significant loss of spermatozoa, estimated in 2/3. They also increase sperm DNA fragmentation and may be detrimental for the reproductive outcomes, especially in couples in whom sperm retrieval was positive but very poor for cryopreservation. And this is a real problem. How to handle the poor sperm retrieval cryopreservation? A number of devices has been suggested to cryopreserve rare spermatozoa. You heard this morning Professor Berkovich, okay? But none of these have achieved a widespread use due to the technical requirement and the cost concerns. And checking the literature, I observed some curious findings. You can see that these are the results in terms of clinical pregnancy rate, live birth rate, and the sperm retrieval, okay, according to the old literature, particularly see what about the meta-analysis and systematic review of corona, okay? And if you check the latest years, there is a list of Chinese authors who obtained a clinical pregnancy rate extremely higher than previously reported, and the same for live birth rate. But if you check carefully their paper, you see that their sperm retrieval rate is very low compared to the previous one reported. And it seems that these authors substantially don't find or don't use very poor sperm retrieval, okay? And so in this case, it is evident that we can expect better result in terms of clinical pregnancy rate and live birth rate when we face patients with a not so severe damage spermatogenesis as some patients we observe every day. So, should we use fresh or frozen sperm from microthese for ICSI cycle in NOA patients? The literature remains poor and controversial on the ICSI outcomes. Studies are often conducted on a small population. Not always the same outcomes are measured and compared, and important parameters in the evaluation of the outcomes are often missing. So, we observed this paper of Al-Mekati in 2018, who was our influencer, and you see that if you obtain a good number of blastocysts and you transfer blastocysts and blastocysts, okay, increasing the number of the transfer, you can obtain a cumulative pregnancy rate very interesting. You can see the red star showing after 4 transfer. And so, therefore, in 2021, in order to reduce the risk in case of only a few sperm recovery obtaining after freezing thawing gametes insufficient or sufficient only for 1 or 2 ICSI cycles, we decided to perform microthese with fresh sperm in the first ICSI cycle, while the remaining sperm is divided into vials and cryopreserved. Transfers are performed with a single blastocyst, usually frozen thawed, at a time. And by means of a few single blastocyst transfers, we have increased the cumulative evolutive pregnancy rate per couple. You can see our recent center data where we compared the results while using fresh sperm for ICSI cycle or frozen sperm. And you can see, in case we use fresh sperm, the clinical pregnancy rate is 42% per transfer, and the live birth rate is 34%. And you can see that in this cohort of patients, the mean quality of sperm retrieval is very poor. There is a high number of patients with poor sperm retrieval. And in fact, the testis histology shows that a great number of these patients have a severe damaged spermatogenesis, either hyalinosis or Sertoli and Oley syndrome, complete or incomplete. Well, if we check the situation on the other cohort of patients with frozen sperm from microthese, we see that the clinical pregnancy decreased to 32% per transfer, and the live birth rate to 24% per transfer. And you can see that in this group of patients, it is there are much many patients with a moderate, good, or excellent sperm retrieval, and also the testis histology is much better. Generally, a lot of number of hypospermatogenesis. And so these represent the cumulative evolutive pregnancy rate theoretically expected after serial blastocyst transfer. You can see here in dark red the clinical pregnancy rate, and in light red, green, the column with the live birth rate, and after the transfer, and this with the frozen sperm, which are clearly lower values. So a curious observation we made, that is referring to our cohort of patients, we operated 52 naive patients, and we had to operate 38 already operated patients, and we can conclude that 70% of these patients were previously operated elsewhere uselessly, because either they were defined as a negative sperm retrieval, or a poor and defined not usable sperm retrieval. Therefore, the statement of the Canadian guidelines that the testicular sperm extraction procedure should be offered to all men with NOA, but should only be undertaken in a center with expertise, real expertise in microthese, and where an ICSI laboratory with real expertise in handling these samples is available, is even more true today and must be sculptured in a stone. And so I must thank you for your attention, and thank all my co-workers.